In this video, I will go over different conditions that can cause conjugated or unconjugated hyperbilirubinemia. So heme, which is a component of the hemoglobin, can be broken down by macrophages into bilirubin. And this bilirubin is unconjugated and is tightly binding to the albumin and is thus water insoluble. Unconjugated bilirubin will be taken up by the liver and become conjugated by binding to the glucuronic acid. So conjugated bilirubin is now only loosely binding to the albumin and is thus water soluble. Next, conjugated bilirubin will be transported via the bile into the intestine, and inside the intestine the glucuronic acid will be removed by the intestinal bacteria and form urobilinogen. Some of this urobilinogen will be reabsorbed, most of which will go back into the bile and get secreted into the intestine, but then some of it will be reaching urine, and inside there it will be converted into urobilin, which has a yellow color and thus gives the urine its yellow coloration. And then the rest of the urobilinogen, which is not being absorbed and is inside the intestine, will be converted via the intestinal flora into the stercobilin, which has a brown coloration, and thus it gives feces a brown color. So now you can see conditions that can block the secretion of biles will cause increased concentration of the conjugated bilirubin inside the blood, which will be excreted inside the urine and give urine dark color. While since there is a decreased level of stercobilin in these patients, because biles cannot be excreted inside the intestine, therefore these patients will have a light colored stools. So just keep that in mind. Conditions that block the excretion of biles into the intestine can present with a dark urine and light stools. So now next we can go over the features of the different hyperbilirubinemia, including the conjugated and unconjugated forms. So as I mentioned earlier, conjugated is loosely bound to albumin and is water soluble, and thus it can cause dark urine, versus unconjugated, which is tightly bound to albumin and thus is water insoluble. And so it's only with the conjugated hyperbilirubinemia that you can get dark urine, versus unconjugated, it doesn't change the coloration of the urine because it's water insoluble. However, since this form keeps on accumulating in the blood and it can cross the blood-brain barrier and therefore lead to kernicterus and possibly death. So for the treatment of this condition, blue light phototherapy is the treatment option for these patients, where the blue light will make the unconjugated bilirubin water soluble and thus it would be able to get excreted. So the first conditions are conjugated hyperbilirubinemia, which is from decreased excretion of bilirubin. And the first form is from decreased extrahepatic excretion of bilirubin, for instance gallstones or carcinoma of the head of the pancreas, or extrahepatic biliary atresia, all of the conditions that block the biliary duct that is outside the liver will cause conjugated hyperbilirubinemia and can lead to secondary biliary cirrhosis. And it's given the name secondary because it's secondary to the medical conditions that are listed here. And then decreased intrahepatic excretion of bilirubin can also lead to the conjugated hyperbilirubinemia. And examples of the causes of decreased intrahepatic include, for instance, hepatitis, cirrhosis, primary biliary cirrhosis, which is an autoimmune disorder of the liver that causes progressive destruction of the intrahepatic bile ducts, and these patients are testing positive for anti-mitochondrial antibodies. The other condition is primary sclerosing cholangitis, which is a disease of both the intra and extrahepatic bile ducts, and it presents by the thickening of the bile duct wall, and thus it causes narrowing of the lumen. And then on the ERCP, you will see the bead-like structure of the bile ducts, where there would be areas of strictures followed by areas of dilation, and then areas of strictures and another area of dilation. And this is a characteristic feature of primary sclerosing cholangitis. You should also know that the primary sclerosing cholangitis is associated with ulcerative colitis, and less commonly with the Crohn's disease. So here is an example of a bead-like stricturing and dilation on the ERCP. So you can see on black arrows, we have the strictures, and then the white arrows shows dilation. Then we have strictures, dilation. And then here we have another dilation, stricture, dilation, and so on. And then the other two conditions that can cause conjugated hyperbilirubinemia are Dubin-Johnson disease, where there is a decrease in secretion of bilirubin across the canalicular membrane, and these patients present with a black liver. And then the final condition is Roter's disease, where there is a problem in the hepatic storage of conjugated bilirubin that leaks into the plasma, and thus it will cause hyperbilirubinemia. So the memory aid that I have here for you to remember that these two conditions are associated with conjugated hyperbilirubinemia is called Dr. Kahn. So D goes for Dubin-Johnson, and then R goes for Roter's disease are associated with conjugated hyperbilirubinemia. The other memory aid that I have for you that will help you remember Dubin-Johnson is associated with black liver. So every time you're calling on the phone, you have to spell out D from B. So you say, for instance, D like David and B like Bob. So these two letters are sounding so similar to each other that it makes me remember that Dubin-Johnson is going for black liver. So let me spell that out for you. D like Dubin-Johnson and B like black liver. So these conditions are going together. Next, we have the unconjugated hyperbilirubinemia, and it could be from excess production of bilirubin, for instance, hemolytic anemia, where from the breakdown of the hemoglobin, there would be too much bilirubin that the liver cannot conjugate them, and thus there would be an elevated levels of unconjugated bilirubin in these patients. And then the other causes of elevated unconjugated bilirubin is from impaired mechanism of conjugation or decreased hepatic uptake. So examples of conditions that can cause unconjugated hyperbilirubinemia include hepatitis, cirrhosis, as well as the physiologic jaundice of a newborn, where due to the immaturity of the conjugating system, these newborns can present with the unconjugated hyperbilirubinemia. And as I discussed earlier with you, the treatment for these patients is the blue light phototherapy. And then the other two conditions that we have is Gilbert syndrome and Crigler-Najjar, which divides into the type 1 and type 2. Gilbert is associated with decreased UDP glucuronosyl transferase, and these patients are usually asymptomatic or may present with a mild jaundice, versus Crigler-Najjar type 1, which is more severe and is due to the UGT deficiency and can cause kernicterus and neurological symptoms. Versus type 2, which is similar to Gilbert, is associated with decreased activity of the UGT, and thus it's less severe than type 1 and is less likely to develop kernicterus. However, since the level of the enzyme with the type 2 Crigler-Najjar is less than Gilbert, this form of the hyperbilirubinemia is more severe than Gilbert. So the level of severity of these symptoms ranges from Crigler-Najjar type 1, which can cause kernicterus, to Crigler-Najjar type 2, which is less severe, and then finally to Gilbert, which is usually asymptomatic. And the memory aid that I have for you is unconjugated. So unconjugated hyperbilirubinemia is associated with Crigler-Najjar as well as with Gilbert syndrome. So you remember for the conjugated, we had the mnemonic Dr. Kahn. It was associated with Dubin-Johnson and Roter, and then Dubin-Johnson, D and B, were associated with black liver. Okay, now that we are done with the disorders of the hyperbilirubinemia, I would like to go over the liver function test that you can use to determine the function of the liver. So aminotransferases like AST, which stands for aspartate transaminase, and ALT are the enzymes that are being routinely used for the function of the livers. So ALT also stands for the alanine transaminase. So in patients that have alcoholic hepatitis, AST level to ALT is more than 2-to-1 ratio. And the way you can memorize it is that alcoholics sit on their ass. And then with conditions that cause viral hepatitis, the levels of AST and ALTs is usually in hundreds to thousands. The next enzyme is alkaline phosphatase, which could be elevated related to liver problems, bone, or gut problems. So conditions that can obstruct the flow of the bile will cause elevated alkaline phosphatase. But just to confirm that this elevation is related to the liver and not the bone or the gut, you will have to measure the levels of gamma glutamyl transferase in these patients. And if the levels of GGT is also elevated, then you can conclude that elevated ALP is related to the liver problem. Next, you can measure bilirubin, and I just discussed that with you. You can have conjugated or direct versus unconjugated or indirect bilirubin to find out the underlying causes of hyperbilirubinemia. Albumin is another protein that is being secreted by the liver, and its level decreases in conditions that causes chronic liver disease. And thus, due to the decrease in the level of albumin, these patients will have decreased oncotic pressure, as a consequence of which fluids will leak into interstitial space and thus cause edema as well as ascites. And so for the treatment of these patients, you can provide them with furosemide or spironolactone to help get rid of some of the fluids. And then the prothrombin time can be elevated in patients with liver disease, and the reason is that liver is producing the coagulation factor 1, 2, 5, 7, 9, 10, 12, and 13. And thus with advanced liver disease, since the levels of coagulation factors are decreasing, therefore there would be an elevated prothrombin time in these patients. And that concludes our discussion of the bilirubin disorders.